AACPDM virtual meeting. We hope you've enjoyed today's free papers, lunch and learns, and instructional courses. We are very excited to invite you back to the general session. We are looking forward to our wonderful talk by Joanne Kurtzberg, and the point you've been waiting for is the point-counterpoint debate on botulinum toxin. I would like to take this opportunity to introduce Bernard Dan, editor of DMCN, and he will be introducing our next keynote speaker.
Hello, I'm Bernard Dan. I'm the editor-in-chief of Developmental Medicine and Child Neurology.
I have no sound, Ben.
Of the Academy, which was founded
Ben, I have
by
no
Dr.
sound.
Ronnie McKeith. Now, it is a great honor for me to introduce Dr. Joanne Kurtzberg, who will present the McKeith's Basic Science lecture. Dr. Kurtzberg is a pediatric hematologist who has developed very promising applications of umbilical cord blood in the emerging fields of stem cell therapies and regenerative medicine at Duke and internationally. Many of us have been inspired by her work. She has been a pioneer and indeed a role model. She's Jerome Harris Distinguished Professor of Pediatrics, Professor of Pathology, Director of the Marcus Center for Cellular Cures, and more. She's also Director of the Pediatric Blood and Marrow Transplant Program and of the Carolinas Cord Blood Bank, and co-director of the Stem Cell Transplant Laboratory, Duke University Medical Center. Professor Kurtzberg has important messages for us with regard to the safety profile of reported cell therapies in children with neurodevelopmental disorders, and also about robust ongoing trials in cerebral palsy and autism spectrum disorders. I'm thrilled that she is this year's McKeith's Basic Science lecturer. Thank you.
Hello, everyone. I'm Joanne Kurtzberg, and thank you for that lovely introduction and for this invitation to share our work with you. I'm going to speak today about cord blood and cord tissue therapies, primarily in children with HIE and cerebral palsy. I work in a center at Duke called the Marcus Center for Cellular Cures, and we're a translationally focused, scientifically based center developing cell-based therapies to treat brain diseases with a goal and a track record of rapid translation from the laboratory to the clinic. The main products we work with are derived from umbilical cord blood or umbilical cord tissue. Although many people say cord blood is a bag of stem cells, it really is more than that. It's a bag of many different kinds of cells. The cell in the circle at the top is the blood stem cell, which is responsible for reconstituting hematopoiesis in a bone marrow transplant. But that cell only represents less than 0.01% of the cells in a cord blood unit. There are other immune cells that people are developing into immunotherapies, and we've focused on the monocytes in the bottom, which I'll show you are a type of cell that is not a stem cell and does not engraft, but it is a cell that signals other cells in the body to promote neural cell repair. And then on the lower left, we also are now manufacturing umbilical cord MSCs, or mesenchymal stromal cells, from cord tissue, not the blood, but the tissue of donors to our bank. We basically manufacture 3 types of therapeutic cells in our work at Duke, all in a GMP clean room laboratory, and all in clinical trials under IND from the US FDA. So the cord blood cells are not only used for a donor for hematopoietic stem cell transplantation, but in our brain injury work are being used like a drug without a transplant or any chemo or immunosuppressive therapy as an infusion to treat children with cerebral palsy, HIE, and adults with stroke. The cord tissue MSCs we manufacture have immunomodulatory capabilities, and they're in clinical trials in a number of diseases, including in children, graft versus host disease, autism spectrum disorder, and HIE. As an aside, they're being used in COVID ARDS and the multi-inflammatory syndrome in children. And then I'm going to tell you a little bit about a cell called DUOC, which is a cell that's derived from the monocytes in cord blood and grows as an adherent cell in culture and has the capability to induce remyelination of the brain. And we are testing it in young children with leukodystrophies undergoing a transplant, as well as planning a trial in adults with multiple sclerosis. Okay, so I'll start by talking about our key observations to date in cerebral palsy and HIE. We performed extensive clinical work in collaboration with multiple investigators to show that there was a rationale to test cord blood infusions in children with cerebral palsy or babies with HIE. And this shows you work from a published paper where we collaborated with Sid Tan, who at the time was a neonatologist at the University of Chicago and is now in Detroit. Who had a baby rabbit model of birth asphyxia, where the rabbits were asphyxiated prenatally, born with CP, and then we gave them human umbilical cord blood cells in the same dose we would a human baby IV, and he looked at their functional outcomes over the first 2 weeks of life. And you can see in these graphs that the blue solid line, which is the treated animals, compared to control animals who only got saline in the dotted lines, the treated animals had improved posture, locomotion, better balance, and less hypertonia or dystonia. And although it's not shown on the slide, it is described in the paper that there were human cord blood cells found in the brain by PCR 24 hours post-injection. We explored many other models, and I'm only showing you tidbits of some of them, but one of the things we did was develop an organotypic model of murine brain slices where we could look at effects of oxygen glucose deprivation, which is a way to mimic hypoxic injury in vitro. And on the upper right, you can see normal brain slice with green neurons, red oligodendrocytes, and pink astrocytes. In the middle, you see injured brain after 45 minutes of OGD, where the neurons have died. And on the right, you can see injured tissue, which was then co-cultured with cord blood CD14 cells or mononuclear cells. And you can see that the neurons don't die and are rescued by the cells. And I'll just mention that this is a property of cord blood cells, but not adult peripheral blood cells. Those studies and many others led us to get an IND to run a clinical trial looking at the effects of autologous or the child's own cord blood infusion on motor function in young children with spastic CP. And as I'll show you, this was a randomized placebo-controlled blinded trial. There were 63 patients. They were at 1 to 6 years of age. They had to have a qualified cord blood unit. And I'll remind you, these are units that the parents banked in a family bank at the time the child was born, not necessarily planning to use them later, but which were available and which we qualified and infused intravenously. Children had to have cerebral palsy with spasticity and a GM-FCS level between 1 and 4. And I'll show you the trial design. The placebo was pink liquid tissue culture media with 1% DMSO, which is the cryopreservative the cells are preserved in, which gives you a smell on your breath when the cells are infused. So everybody got pink stuff that made them smell. And the primary endpoint was the change in the GMFM score at 12 months. And the children were followed for 2 years. We developed ways to qualify the cord blood units because they were banked in many different units around the world, or many different banks, around the world. And we set specifications which the FDA approved in our IND, that the cord blood unit had to have a certain number of cells, it had to have a certain viability, the sterility cultures had to be negative, the donor screening test on the mom, which is the routine way you screen for cord blood, had to be negative. And then we obtained a sample from the cord blood unit prior to bringing it to Duke to confirm that it really was that child's unit by checking HLA on the child and HLA on the unit and showing that they matched. I'm sure you're all very familiar with the GM-FCS levels. We allowed children levels 1 to 4 and ages 1 to 6, which got us into trouble a little bit between the 1 and 2-year-olds because the changes in that age group are not as well characterized by the score. But what we did was we made our major endpoint a change from baseline to 1 year in the GMFCS level. And I probably don't have to tell you, but a child who is younger and has milder CP is going to make more normal gains over that time period than a child who is older with more severe CP. And we required that the change had to be at least 30% above what the predicted change by this GMFCS age and level at study entry. So this is just the study design. The children were qualified, the cord blood unit was qualified. They came for a visit where a neurologist and developmental pediatricians and physical therapists saw them. And then they were enrolled in the study and randomized to either get cord blood at baseline, followed 12 months later with a placebo infusion, or placebo at baseline, followed 12 months later with a cord blood infusion. And they were all evaluated again at 2 years. And the order of the infusion, meaning placebo or cord blood, was blinded to everyone caring for the patients and testing the patients and the parents themselves. So the results of this study basically showed both on the GM-FM 66 analysis and were confirmed on the Peabody analysis or Peabody scale. So in panels B and panels D, that children getting placebo or low-dose cord blood, so placebo's in the blue bar, low-dose cord blood is in the red bar, did not have improvement beyond what the placebo group did, but children getting higher dose cord blood, which turns out to be the dose we use for transplant, which this was not, but in the green, had a statistically significant improvement in motor function at 12 months. And to look at the strength of that finding, we then combined all children 1 year post actual cord blood infusion and evaluated them again. And we looked at the high dose and low dose group to see if there was a dose effect. And this just shows you that there was not a difference in the type of CP, the age of the child, the baseline GMFCS level. Only difference between these groups were the median infused cell dose. And we saw in the middle panel that there was a statistically significant improvement in motor function in the children getting the higher dose. And in the lower right, that was accompanied by increased in the motor tracks in red lines and the nodes between those tracks in the turquoise dots to a p-value of less than 0.001 in the children who improved. So we had children who improved, was correlated with increased connectivity on whole brain connectivity on MRI. And we then, in the upper right, confirmed that in a group of children where we gave sibling cord blood, but we could give the higher dose. And again, saw the same improvement in GMFCS score at, in this case, 6 months. Just because I think a picture can sometimes be 1,000 words, here's a child enrolled on the study. And in the top panel, you can see what he looked like at baseline. So he's walking with a walker and he's spastic and has braces. And in the bottom panel, You can see how he looked a year later. And this was a child who got a high-dose cord blood when we broke the blind on his first infusion. So we considered this more than the expected change you would see in a year in a child who started at the baseline in the upper left. But all the children were filmed. They were all evaluated by independent raters who did not know what they were treated with. Now, although we were encouraged, I guess, by this finding, and I didn't mention, but there were no adverse events or any kind of serious reactions to the cord blood infusions. We know that most people don't bank their child's cord blood, and we also know that many of the children who end up with CP are preemies or have complicated births and won't have access to banking of their own cord blood, even if it was intended. So we really are interested in finding an allogeneic or donor product that could have an effect and be available to anyone in need. So we've looked at cord tissue MSCs, which we create from an umbilical cord tissue that is donated by a donor to our cord blood bank, harvested from a male baby at term, delivered by C-section, so we can preserve sterility after maternal informed consent. And we do the normal donor screening and qualification, digest the tissue and expand it to passages, cryopreserve it, characterize it, sterility, endotoxin, adventitial viruses, and potency assays. And that is a product that we now have in clinical trials under IND. When we looked at activity of the cord tissue MSCs, they are anti-inflammatory and they modulate neuroinflammation. We test them for their ability to suppress inflammation by requiring that they suppress T cell proliferation in a third-party MLC. And then we develop the assay that's shown here in green to assay whether they can suppress microglial activation. So on the left, you can see normal murine microglia stained with CD68. We activate them with LPC, and then we co-culture them with a lot of MSCs that we're testing for the clinic, and they have to suppress that activation at least 70%. All of this is now on the right, done digitally and analyzed on a computer, but the lots that are going into the clinic have to pass that assay. And we have these cells in clinical trials in multiple diseases, and I don't have time to tell you about all of them, but I'm going to talk about our use in a phase 1 trial in autism, phase 1 trial in babies with HIE, and a phase 2 trial comparing it against cord blood in children with cerebral palsy. So first, we tested this in 12 children with autism, ages 2 to 11. And we did not have any other qualifications other than they could not have a genetic disease or autologous cord blood available. And we did a dose escalation of 1, 2, or 3 doses of 2 million cells per kilo per dose, 2 months apart over a 6-month period. And they were then evaluated for response both clinically and some behavioral outcome measures for autism and also for safety. And the cells were safe, the infusions were well tolerated. On the right, those graphs show you that half the children developed low titer, broad spectrum anti-HLA antibodies, and the antibodies were targeted against HLA loci that the patient did not possess, but were part of the MSC donor HLA type. And when you give MSCs, you do not match. So we have taken that into a study that's ongoing now in children with autism, giving a higher dose of 6 million per kilo. And again, it's the same design of placebo-controlled blinded crossover with a 6-month endpoint, and that is ongoing right now. We then, I remind you of the autologous cord blood study in kids with CP, where in green we saw the dose effect, which showed an increase in motor function in kids who got a dose higher than 25 million cells per kilo at 1 year. So we have just finished a study called Accent CP, which was conducted in 90 children ages 2 to 4 with spastic CP with a GMFCS level of 1 to 4. Their etiology of their CP had to be HIE, PVL, or in utero stroke or bleed. And they were randomized and stratified by GMFCS level and etiology of CP. And in this study, we tested a very high cord blood dose using donor cord blood cells from our public bank at 100 million cells per kilo to really ask, is this a true finding and is there a dose effect? And we compared this to a cohort of children on the same study who randomized to get 3 doses of the cord tissue MSCs, and then a natural history arm where the children were observed for a year and then given a cord blood infusion at the end of a year. So everyone on the study was treated, but the evaluation was primarily done at 12 months, and we compared children getting high-dose allogeneic cord blood, which was matched at 4 of 6 loci, to MSCs in 3 doses to a natural history group. This shows you the demographics of the population, because of COVID, we had some issues with getting 12-month follow-up on all children. So we did 6-month follow-up plus projected 12-month follow-up for a group that couldn't complete the 12-month follow-up. And it shows you here that we had a slightly higher prevalence of stroke etiology and a lower prevalence of PVL etiology in the level 4 group. So that's just the way the randomization worked out. Bottom line, the study showed that cord blood improved motor function at 12 months in these children with a p-value of 0.017, but that the cord tissue MSCs had no effect. We didn't know what to expect, but it does make sense because CP, as you all know, is a static injury. It's not really, the brain is not inflamed at the time we're treating these children. And since MSCs work mostly through modulation of inflammation, they may not be as effective in this setting. Cord blood, on the other hand, through the monocytes, does signal formation of new pathways, and that may be how it's working. I'll switch gears for a minute and show you our data in babies with HIE. We performed a phase 1 open label, non-controlled trial, which is published in JPEDS in 2014. And we treated 28 babies with cooling plus and 2 infusions of their own autologous cord blood on day 1 and 2 of life. And we compared those babies to babies who were concomitantly cared for in our nursery, but not randomized, who happened to be cooled and did not have cord blood. And we saw, 1, that the cord blood infusions were well tolerated, and 2, that there were twice as many babies surviving at a year with 3 normal Baileys if they got cord blood with cooling compared to cooling alone. And we realized that that's just descriptive. So we planned a phase 2 randomized placebo-controlled trial, which was supposed to enroll 160 babies over 3 years. And we involved multiple centers in this trial. And what we found was that we had accrual difficulties, and we had to stop enrollment at 37 babies. We screened 162, and more than half of those were eligible, but they didn't have cord blood collected. So the cord blood collection was a real barrier to bringing this therapy to the masses, if you will. And there were many reasons why the cord blood wasn't collected, including just the complexity of the delivery, or if there was an abruption, or not enough manpower, etc. Interestingly, the analysis of the first 29 babies that had 1 year follow-up did again show a trend towards improvement in survival with normal function in the treated versus the placebo group, like we saw in the phase 1 study. But we started to think about how we could again explore this in a more realistic fashion. And we decided to explore an off-the-shelf product using the cord tissue MSCs. And let me just say, we weren't comfortable giving donor cord blood to newborns because donor cord blood has active viable lymphocytes, and could cause GVH in a baby that doesn't have a normal immune system. But the cord tissue cells, A, don't engraft, B, can't cause GVHD, and were a safer product to give to newborns. So we did a 6-baby pilot, giving MSCs to all babies. 2 received 2 doses and 4 received 1 dose, and they all tolerated the therapy well. There were 4 babies with moderate HIE and 2 with severe HIE. They were all cooled. Interestingly, these babies all did well. They were discharged from the hospital at 9 to 10 days. Their 9-day MRIs were all normal. And at 1 year follow-up, they're all doing well and do not appear to have any neurologic deficits. So we're going into a phase 3 trial, which will be placebo-controlled and blinded, but we will biologically assign the cell group to either autologous cord blood or MSCs based on whether their cord blood was collected. Sorry. I'm having a little trouble with the pointer. Okay, and lastly, I'll talk about a cell we call DOC, which we derive in culture from cord blood monocytes, and which has the ability to myelinate the brain. So you might ask, why did we want to do this work? In my other life as a transplanter, we transplant children with leukodystrophies. This is a real transplant where they get chemotherapy and their cells are replaced by donor cells from a cord blood donor that not only repopulate their blood and immune system, but also provide enzyme replacement through cellular engraftment in leukodystrophies that are caused by enzyme deficiency. So these are children with Krabbe disease. The girl on the left was transplanted at 19 days of age, the girl on the right at 21 days of age. They both had siblings who died of early infantile Krabbe disease in the first couple of years of life. And you can see their outcomes are really different. So transplant extends life and it also improves function, but some kids, like the kid on the left, will be nearly normal, and other kids, like the kid on the right, will have trouble walking by the time they're 5 to 10 years of age and will be in a wheelchair by the time they're teenagers. The images in the middle show fiber tracking of the corticospinal tracts on each of these kids at 2 days of age on MRI with DTI. And you can see that the tract on the little girl on the right is abnormal. And that probably explains her problems. Now, in a kid who underwent a transplant for Krabbe in the upper left, we were able to show who died 10 months post-transplant. We were able to show donor cell engraftment in the brain. Little girl was a girl. She was transplanted with a little boy's umbilical cord blood. And in this picture of her cortex, you can see with XY fish that there are many male cells. The green dots are Y chromosomes. And when we looked at what those cells were, we saw they were microglial type cells. And we went back to the cord blood unit and attempted to grow those. And the cells swimming around on the bottom left are the cells we've established from cord blood units that we call DUOC. And those cells are capable of remyelinating the brain in a Cooper-zone model shown in the middle, and also stopping a progressive ascending paralysis in what's called the EAE model, which is a model of MS. And these cells are capable of replacing enzyme, modulating inflammation. They drive oligodendrocyte proliferation, and that's how they promote remyelination. So we have them in a clinical trial augmenting a transplant in children with leukodystrophies, where we're giving them intrathecally after a standard transplant and engraftment. And then we're following outcomes with the goal of getting engraftment earlier than a transplant would produce in the brain. And we have treated 28 children who, I'm having trouble with the slide again, sorry, who have done well. We moved to using a whole cord blood unit for the DUOC therapy because we could get a higher dose, and we added hydrocortisone to the formulation to prevent reactions. But it's really hard to be sure there's efficacy from these cells using it alongside a transplant. So we have now gotten funding to do a trial using DUOC alone in children with MS. I'm sorry, in adults with MS to really look at efficacy. And I'm showing you this just to say there may be other cellular therapies that are coming along that will be even more effective than standard cord blood. Now, some of you may have heard that we also have an expanded access program here. So FDA allows you to have under IND expanded access cell therapy while you are doing relevant clinical trials to determine whether or not the therapy is efficacious if you have shown safety of that therapy. And so we opened our expanded access program a couple of years ago. Come on, slides. Thank you. After we had had a compassionate use program for many years before that. So all in all, we've treated 865 children with autologous cord blood infusions on the compassionate release protocol. They had HIE-CP, congenital hydrocephalus, apraxia, stroke, or hypoxic brain injury. And then more formally, since November of 2017, we have this expanded access protocol, which allows us to treat kids with an infusion of autologous or sibling cord blood if they have a diagnosis of brain injury and are not eligible for one of our ongoing formal clinical trials. This could be extended if we have data to show benefit in the future to allogeneic cord blood and cord tissue MSCs, but right now we really don't have the bandwidth to do that. So we've treated 400 patients on our IND. We have 600 waiting and screening and 1,600 waiting for follow-up contact, and more than 20,000 who've contacted us. We just forged partnerships with Rutgers and MD Anderson's pediatric programs to extend access to infusions at their sites under the same IND. And our hope is that we will go eventually to the FDA for approval through a BLA so that we can, if we prove in phase 3 the therapy remains effective, make this part of clinical care. This just shows you the schedule of children coming for infusions. There's a big workup before they get here that qualifies their cord blood unit. Then they come for a day for a physical and history and blood work, and then a few hours for the infusion in our day hospital, and follow up the next day to make sure they did well. I'll just show you a little data about safety outcomes. The first 385 patients we treated, 219 got autologous infusions, 166 got sibling infusions, 235 had autism, and 104 had cerebral palsy, and 9.9% had infusion reactions, all of which occurred during the infusion, all of which were treatable, but basically they were in the category of hypersensitivity reactions, and 24% had hypoxia, 14% had rash, 5% had hypertension, and it generally wasn't affected or impacted by diagnosis. The point of showing this is to say this shouldn't be done casually, should be done in a medical center that has the ability to monitor these kids and treat reactions if they occur. But in that setting, they're safe. So in conclusion, I would say that both autologous and allogeneic cord blood infusions show excellent safety profiles, and they suggest efficacy in phase 1 and 2 clinical trials in children with various types of brain injury. The cord blood monocytes appear to be the active cells, which is in cord blood, which is a heterogeneous cell product. And we do see a dose effect. And with appropriate dosing, these cells appear to improve motor function in kids with CP. Cord blood also shows promise in babies with HIE, and cord tissue cells may be an additional source of cells to treat children with autism and HIE. These are all diseases where right now the cells have the potential to treat diseases with unmet needs and maybe change human lives. So our future plans are to finish this phase 2 study called Impact in children with autism, testing the MSCs, and for children with CP to conduct a multi-center randomized phase 3 placebo-controlled trial with cord blood. For HIE, conduct the study I mentioned with cord blood or MSCs, and for DUOC to take that into adult patients with MS. So I feel very optimistic that there is going to be a role for cell therapy in these children, but I feel also very responsible to continue to do these studies to make sure that we show not only safety but efficacy before they come into the clinic. And we are following the traditional FDA pathways to do that. I have to say that I could not be speaking to you without an incredible team of people behind me. It really takes a village to do this work. And we have both the clinicians and the cord blood bank and the laboratories that manufacture the cells, and our colleagues in neonatology and neurology and developmental medicine and rehab medicine who have worked with us to do this, produce these results. And I also need to mention that everything I showed you has been done under IND. The patients aren't paying for the therapy on the clinical trials. They've been supported by the Marcus Foundation and the Robertson Foundation, the Dana Foundation, Cure CP, and the autism phase 1 study was in part supported by PerkinElmer. So I'll stop there and be happy to take questions.
Thank you. That was a fabulous talk. We really appreciate it. And I'm sure there are a lot of questions. I'm going to start with the first one. Why were children of GMFCS level 5 excluded from your study? They might have the most to gain.
Yeah, we excluded them from the study because of safety concerns. We didn't really know when we started this whether an infusion of cells could compromise their respiratory status, if they had infusion reaction, started wheezing or had bronchospasm, whether if they were already compromised in terms of their ability to cough or pulmonary toilet, that would get them into more trouble. And we also were concerned about having those children travel to us because most of the children in our studies came from not only other places in the US, but other countries around the world. And so we didn't want to take that risk for those families until we knew that we really had something to offer. We have had level 5 kids come to the expanded access protocol, and we are following their outcomes.
That's great. In the ACCENT CP RCT trial, can you provide further details on the comparison of the GMFM change at 6 months of the children receiving cord blood versus the comparison waitlist group?
So the stats I showed were showing comparison of the cord blood group to the observation group, and then the MSC group to the observation group. And we looked at both raw GMFCS scores and the change at, in this case, 6 or 12 months. And we also looked at the change score, which was the expected minus the actual score. And in both cases, the cord blood group showed significant changes, whereas the MSC group did not.
Okay, so the last question is, due this exciting news that you are showing, should we recommend banking the newborn's cord blood for all children with a high-risk pregnancy or risk factors of developing neurodevelopmental disorders?
So I would say yes, when it's possible. It's not a bad idea to recommend saving the cord blood. But there's kind of a flaw in that recommendation, and that's because most autologous cord blood collections, particularly in children who are high risk for these types of problems, often are too small to yield enough cells to get to the cell doses we're talking about. And I didn't say it clearly, but in our sibling study and then in Accent CP, where we used donor cord blood, we had incrementally more cells available to treat the child than in the autologous study. So if people don't save the cord blood, that's okay. Or, if it's a preemie or it's an abruption birth or whatever it might be, I don't want anybody to feel like they've lost an opportunity for therapy, because our best data is actually with donor, publicly banked, FDA licensed cord blood, which is available to everyone.
Great. Thank you for your wonderful presentation. I'm sure there are many more questions, but we appreciate your time. And next we will go to the Mentorship Award, and it'll be introduced by Lane Wimberly.
Good evening. I have the privilege of introducing the 2020 AACPDM Mentorship Award recipient. For the vast majority of the members of this organization, this gentleman needs no introduction. Our 2020 president, Mauricio Delgado, has been selected for this award. He is a professor of neurology at the University of Texas Southwestern Medical Center in Dallas, Texas, and has held clinical appointments at Parkland Medical Hospital as well as Children's Medical Center. His primary clinical practice has been at the Texas Scottish Rite Hospital for Children in Dallas, where until recently, he was the chairman of the Department of Neurology. Academically, he has had a prolific career with greater than 100 publications and presentations, multiple grants, and leadership roles on local, national, and international organizations. He has had an incredibly successful academic career. However, the Mentorship Award is not based upon his resume. Instead, recipients have demonstrated significant influence on patients, families, and other medical professionals. In 1992, he created the International Child Neurology Fellowship Program at Texas Scottish Rite Hospital for Children. This program has welcomed 10 to 12 physicians and medical professionals, primarily from Mexico and adjacent Latin American countries, to join his clinic in an observation role each year. In total, more than 250 international fellows have benefited from this program. Many have come from financially disadvantaged countries, and Dr. Delgado, recognizing the value in training these young professionals, has arranged significant financial assistance for them. Several fellows have completed his program and then gone on to do accredited year-long programs within the United States. Dr. Delgado was also instrumental in helping to create the Mexican Academy of Cerebral Palsy and Neurological Disorders. He coordinated a coalition of physicians and other medical professionals to found this organization. He has never accepted a leadership position, but has humbly made himself available to help guide and assist the organization as it has grown. Outside of the field of medicine, Dr. Delgado and his family have established a scholarship program in Dallas to help children attend private Catholic schools. Each child has at least one parent born outside of the United States, and this program has grown to include a formal board of directors and continues to expand its influence within the city. In the last year, more than 30 children have received full scholarships to attend these private schools. When notified of his selection for this award, many prior mentees were eager to volunteer to contribute to his introduction.
Congratulations, my dear Dr. Mauricio Delgado. As physicians, our life get touched by many people, be it family, friends, professors, or patients. But it is only by a handful of people that our life gets transformed in the way Dr. Mauricio changed mine. As such, I feel very happy and proud by partaking in this show of gratitude and recognition for merit. For it was your generosity which gave me and my peers the opportunity of studying abroad at the Texas Scottish Rite Hospital in Dallas. You allowed me to learn a better form to do medicine. Your contagious passion for knowledge and your empathy towards the sick children and their family turned me into the neurologist and professor I am today. I am a better person and even a better physician thanks to you. Thanks for influencing my life with your magic and science. May God bless you with a long and healthy life.
Dear Dr. Delgado, congratulations for this deserved award. You have shared your knowledge for years with doctors from all over Latin America and many parts of the world. Thank you for that. But also you have extended your hand, giving us your support, friendship, and advice to be better doctors, but also to be better persons, always insisting in the importance of the family. You have been a great influence in my life as a teacher with your knowledge, but principal with your example. Thank you. Thank you for your support in my career and in my postgraduate course without asking anything in return other than my eternal gratitude, friendship, and acknowledgement for your work. Thank you, Professor, and congratulations.
I feel incredibly grateful to have found a mentor in Dr. Delgado so early in my career. I have grown so much from his guidance and his mentorship. Dr. Delgado, for example, has encouraged me to not only answer the questions that need to be answered now to better serve our patients, but also to seek new questions that will need to be answered in the future. Dr. Delgado is an excellent example of a caring and thoughtful physician who treats his patients and his colleagues as if they were his own family. He is always willing to listen and give advice no matter where he is in the world. He has helped me establish my practice as a young physiatrist and has helped me chart the unknown waters of academic medicine. I, just like many people undoubtedly all over the world, cannot think of a more deserving individual for this award.
Dear Dr. Delgado, I felt so happy when I learned that this academy gave you the 2020 Mentorship Award that I wanted to share this news with everyone. And I did, and most of them were clapping and were even jumping because they knew that this recognition was needed for a person like you. You may not know how big a mentor you have been to me and to others, but I think I have one word to share with the Academy about why you deserved this award. You've not only led me to go beyond my limits, to go beyond what I thought I could do. You've continued pushing me and showing me ways to go further than I expected. And not only that, but to share with others what I had learned from you. I don't have enough time to tell you how big the influence on me has been, not only professionally, but as a human being. I always had a word of advice, of warning, and of encouraging from you to achieve things that I wouldn't think I would ever be able to do. And it is not only me, because that would only be one person. You throw your seed everywhere. You share what you have and what you know with everyone. Sometimes that seed grows, sometimes it don't. But if you could imagine all the influence you have in people, not only colleagues and professionals, but patients and families, because I know that that is what moves you to work and share. that I decided to graphically show you all the influence you may have in everyone. And by the way, I do remember the reason for all that we do. Thank you for being the best mentor.
I'm very honored that my partner and friend, Mauricio Delgado, has received this award. I only wish we were all able to celebrate in person. Mauricio, congratulations, and we look forward to seeing you soon.
Well, thank you, Lane, Fabiola, Jorge, and the Academy for giving me this award. To tell you the truth, I'm still in denial. Why? Because I know there are many others who deserve this recognition more than I do. And because I'm not that special. I just tend to cheer anyone up who has a desire to unmask their potential. Maybe they should change the name of the award to the Cheerleader Award. Well, since I can do it and I have the mic, I want to use this opportunity to thank the cheerleaders in my life, starting with my parents, who always encouraged me to pursue my dreams. And then Maria, the love of my life, who for 43 years has been the most enthusiastic, faithful, and patient cheerleader. And also to those mentors who believe in me and help me unmask my potential, which is a task that never ends. And that is what makes life so exciting. I want to especially recognize Dr. Peter Humphries in Ottawa, Canada, who is one of the best and most compassionate pediatric neurologists I have ever known, and who one day believed in me and gave me the opportunity to become a pediatric neurologist. So wherever you are, Peter, thank you. Great part of this award is yours because you taught me by your example how to be a neurologist, but also how to be a cheerleader. So I want to encourage all of you to think about the future. The future belongs to our students, residents, fellows, junior faculty, and team members. Are we helping them unmask their potential? Are we helping them see what's important, why we do what we do? I think this academy is the right place to do that. It is an incubator where love and support for each other and putting those that we serve at the center of our decisions and actions encourages our young colleagues to do their best for the right reasons. So thank you, AACPDM, and those who have worked so hard to make this organization such an amazing place. We still have a lot of work to do, and that is where you come in. Unmask your potential and make a difference. Thank you so much.
Congratulations, Mauricio. You are very deserving of that award. We want to make sure that you take the time to check out all of our award winners this year. This year, Christopher Hendricks has won the Corbett Ryan's Pathways Pioneer Award, so there are many more. Please take the chance to check them out.
I want to thank you all for joining us tonight for our point-counterpoint lecture. But before we get into that, I want to let you know that you should stay on for a special recognition that we are doing after this counterpoint. So I'm hoping at this point that you all are as excited as I am to be in the room where it's happening, even if it's virtual. We are excited to have a live and interactive plenary session debating the role of botulinum toxins for spasticity management in children with CP. The question we posed to Drs. Mark Gormley and Jason Howard was, should botulinum toxins be used for spasticity management in children with cerebral palsy? In the corner advocating for the pro side, Dr. Mark Gormley is a pediatric rehabilitation medicine physician at Gillette. He treats children and adolescents who have cerebral palsy, brain injuries, spinal cord injuries, neuromuscular disorders, and other conditions with a special interest in spasticity management. In the corner advocating against the use of botulinum toxins is Dr. Jason Howard. He's a pediatric orthopedic surgeon in the Division of Cerebral Palsy in the Department of Orthopedic Surgery at Nemours Alfred DuPont Hospital for Children in Wilmington, Delaware. He has also practiced all over the world, including in Doha, Qatar, and also in Canada. He has had a long-standing collaboration for research with Dr. Walter Herzog's team at the Human Performance Laboratory at the University of Calgary, investigating the pathophysiology of CP muscle. And for those of you watching from your devices, well, that's all of us. So for all of you, this is how this session is going to run. Dr. Howard on the con side is going to go first. He will present for about 15 minutes. Then Dr. Gormley will go and do his side for about 15 minutes. Each of them will have a 5-minute rebuttal. And then there will be a 20-minute Q&A. Please get your questions in early, because I suspect we won't be able to answer all the questions that you are going to have for us tonight. And again, please stay on for a special recognition that we are doing after this session. So with further ado, I would like to bring on Dr. Jason Howard and Dr. Mark Gormley.
Well, thank you very much, Jolene, and it's certainly my honor to be here representing the con side of this question, which is an important one. And I want to thank the Academy for inviting me to partake in this point-counterpoint with my esteemed colleague, Dr. Gormley. Sorry, get the clicker going here. I have some disclosures, but none of them are industry related directly. But I will say that I have been a prolific injector of botulinum toxin. Can you hear me? I have been a prolific injector of botulinum toxin for dynamic muscle contractures and CP over my first decade of practice, but I haven't done that for a number of years now. And this is what we're treating, isn't it? Here's a spastic or dynamic contracture in the soleus, called R1, according to the Tardius scale. And this is our target for botulinum toxin, or at least it's the primary target. And here's, if you look at Mercer Rang, the great educator from our point of view, he gave some cartoons which showed the progression of musculoskeletal pathology in CP, which starts off with that dynamic muscle contracture, leading to a fixed muscle contracture with growth, and those fixed muscle contractures pulling on bones to twist them and put bones out, or put joints under instability conditions. And to counteract this whole process, botulinum toxin has been introduced at this early stage in the hope that we mitigate the whole thing and put me out of business. And so the natural goals of botulinum toxin are to prevent these long-term fixed contractures, but also to improve function. Certainly that's what I had in my mind at the beginning of my practice when I embarked on all this and had botulinum toxin as part of my practice. I wanted to put myself out of business. And here's the traditional view of how botulinum toxin works in muscles injected. You get a reliable reduction in spasticity, but you get a complete recovery at about 6 months. And it's been touted to be safe, effective, and reversible. But is it? I mean, really, is it? Here's a kid who's had botulinum toxin over their childhood, multi-level, and I thank Nancy Lennon for this child helping me put these videos together. But you can see at age 3.5, just before botulinum toxin, this kid's got a jump style gait with flexed knee. And if we go on to after a botulinum toxin at 5.5 years, still flexed knee, a little bit of apparent equinus, some crouch, which progresses at 8, still is very flexed knee occurring here. And then at age 10, having a slower walking velocity and a decrease in their GMFM. I asked my 8-year-old daughter what she thought if we helped this child, and she looked at me as if I was crazy. You can see how this child over the course of their early childhood has just really gone up their gross motor function curve. But what we don't expect is this decrease at 10 years of age, and over the course of this of their gait analysis over this time period, we saw this kid go into progressive crouch gait, which is not a sustainable way to walk. This prospective cohort using three-dimensional gait analysis showed us some insight into this progressive crouch pattern, which showed no improvements in kinematics, but some improvements in ankle dorsiflexion for sure, but unfortunately at the expense of some knee flexion in many of these patients. And crouch gait, as we talked about, is not really sustainable, certainly not our goal. If you look at the vast amount of literature right now, I mean, it pretty well points and suggests that spasticity reduction doesn't prevent muscle contractures, whether it's by botulinum toxin or other means. It doesn't prevent bony deformity either, and it doesn't decrease the need for orthopedic surgery. So I still have a job, thankfully. So why do we treat spasticity at all? Maybe is it for function? I mean, that would be good, wouldn't it? So thankfully, there are some fastidious and patient people, very smart, who put the synthesize the literature and can give us some answers with respect to all the literature that's out there. Well, in 2000, when the first Cochrane review came out with respect to this, there were only 3 RCTs with small sample sizes, short follow-up. And the key findings were that, yes, ankle dorsiflexion had been improved, but there was no improvement in function or gait. And their conclusions were that really we need more data. We need long-term follow-up, functional outcome measures. Let's get away from just spasticity reduction and these short follow-ups. So Francesco Blumetti and his friends from Brazil thankfully repeated this Cochrane review in 2019. And 20 years later, let's see what they found. In the short term, we found that actually botulinum toxin does pretty well against placebo. Isn't that fantastic? I mean, that's what we would hope for, wouldn't it? It also does okay against PT, but there's very low evidence there. But at least we're looking at gait analysis and function rather than just spasticity and range of motion. Serial casting was not inferior to botulinum toxin for any of these outcome measures. If we go to the longer term now, from 3 to 4 months, you can still see these tick boxes on placebo and PT, again, low-level evidence, but no superiority over serial casting. Moving forward to greater than 6 months, a lot of those tick boxes go away. And if you look at moderate evidence, not very low evidence, but moderate evidence with moderate effect, really, there's no superiority of botulinum toxin over PT, placebo, serial casting, and there's just not enough evidence to get for orthosis. So after 25 years of botulinum toxin, is this what we were waiting for? It's not what I was waiting for. I would tell you, if you haven't looked at this study from the Netherlands, looking at the effectiveness of botulinum toxin as an adjunct to PT or casting orthosis, I really say you should look at it right now, or at least after this debate. This is a pragmatic RCT looking at GMFM, quality of life, activity level, and cost. And they found that the addition of botulinum toxin didn't improve any of the outcomes and was a significantly higher cost. An interesting quote in their discussion was that they said research questions have mainly been based on an implicit assumption that botulinum toxin is the most active component in combined treatment periods. I mean, most of the studies look at botulinum toxin versus botulinum toxin something, not botulinum toxin in something versus that something alone or other things. So I have to wonder, has botulinum toxin been taking credit for good goal-directed PT and casting? Let's switch gears now to hip displacement, because this is kind of a hot area in botulinum toxin management. I was lucky enough to be involved with this study from the population-based cohort of Melbourne, which found a linear relationship between hip displacement and GMFCS. And that's been replicated with other registers, including this one in Sweden. What we didn't expect to find was that motor type didn't seem to matter with respect to the incidence of hip displacement. Hypotonic kids had hip displacement at the same rate as hypertonic kids, with or without contractures. And this was actually purported right back in 1950s by our first president of the AACPDM, Dr. Phelps. So we feel that abductor insufficiency is the real, and negative features such as weakness are the real reason behind hip displacement. You can see this kid with SMA, spinal muscular atrophy, and CP, GMFCS level 5, hypotonic and hypertonic, looking pretty darn the same, almost the same. Despite this, the Australian group then went on to do an RCT, which caused a lot of controversy, understandably, looked at hips at risk, and the Melbourne cohort of this initial RCT was followed up to 10 years. What they did was when they treated their hips every 6 months for 3 years in an abduction brace, and then looked at hip outcomes. Well, what they found was that whether you had botulinum toxin or not didn't impact on whether you had surgery or not. And if you had surgery, it didn't have any impact on what type of surgery you had either. And at that 10-year follow-up, there really was no change in hip morphology or the need for surgery. Although you could say one positive aspect was it delayed the need for adductor surgery by about 18 months. But in the end, all the hip outcomes were the same. So was it really worth all that money? And Stacy Miller and others did a systematic review of the literature around this, and they called this study the highest level of evidence. If we knew then what we know now about CP muscle, maybe we wouldn't have acted so quickly. We now know that CP muscle is small and short, and sarcomerogenesis and growth are impaired. We know that connective tissue is increased compared to typically developing children. We know that the basic contractile element, myofibrils, with their long, are elastic and have very long, weak sarcomeres. We know that the satellite cells, which are responsible for muscle repair and myofiber generation, are decreased in number and in function. And as we learned back on Wednesday, epigenetic abnormalities are also a big part of this, and maybe at the core of all of this cascade of issues that happen. One of these studies really stuck with me, and actually, as Jolene had suggested, I was in Calgary for my initial part of my career, and I got to know Walter Herzog's group, and particularly Raf Fortuna up there with his sporting a COVID haircut, I would say, there in the corner. They used a clinically relevant injection protocol, 3.5 unit per kilogram, reasonable dilution, and 3 treatment groups in this New Zealand white rabbit. They had botulinum toxin times one injection, and then 2 injections spaced every 3 months, and 3 injections spaced every 3 months. They looked at the muscle 6 months after the last injection, and you can see the control there on the right, and after a single injection down below that, with 41% decreased contractile tissue after 1 injection. They also found a 55% decrease in the torque generation. Interestingly, the muscle mass was constant because that contractile tissue was replaced with scar. So you have to be a little bit, have to be thoughtful when you're looking at studies which look only at areas or muscle volumes as an outcome measure in these studies. People have said, well, that rabbit, 6 months is not very long. You should have looked at it longer. They should have looked at it longer. But a rabbit's year is a lot shorter than a human year. So this is actually a very long time for a rabbit, which makes me think that botulinum toxin is not as reversible as we might think. This is not just in Canada. These reports have come from all over the world. Here's Jessica Pingel's group in Denmark, which showed after 1 injection decreased contractile elements almost 50% and an upregulation of scar tissue. This is in a rat. In another mouse model from San Diego, they've found reduced power, reduced fiber size, increased fat, and increased collagen after 1 injection. And once you put another injection in there, 95% less torque. This is a little bit startling, and we're finding it from not just one center, finding it with many centers with different techniques. This is not news. When I looked back at the initial literature, most of the animal studies were in chicks looking at some axonal sprouting and things, and almost nothing on muscle. But there were a few studies, including this one from 1970, where they injected mice gastroc and found that after 4 weeks, 6 weeks, and even after 6 months, there was still substantial atrophy associated. And remember, this is a long time for a mouse. So much for muscle recovery. I mean, this was known in 1970. Why didn't we do a little more about it back then? I was astounded to see last year that the FDA had finally approved botulinum toxin for use of lower limb spasticity in children. But I almost forgot that it wasn't approved. What took it so long? 25 plus years to FDA approval, really? It's a bit astounding. It's been a long journey of human experimental trials, which focused mostly on spasticity reduction and not function. But why so long to prove safety and effectiveness? I'm sure there's a backstory, but it's still an awful long time. The typical FDA drug approval pathway is as you see here, but the starting point for almost every drug is basic animal research. And in botulinum toxin, we did have that. I think most of you do know this study by Aidan Cosgrove and Kurt Graham in 1992. A good starting point. Hereditary spastic mouse. They injected the gastroc with botulinum toxin had controls and found that the injected group that showed no contracture or normal muscle growth. But this was just a starting point. They had no histology, no histochemical analysis. But that was enough to give the green light to go for botulinum toxin with some clinical trials, and it was off to the races. But I wonder if they had to look at that muscle and saw what we know today, would it have been as fast to be adopted? I don't think so. So I would argue that botulinum toxin should not be used for spasticity management in children with cerebral palsy. There's a lack of functional benefit despite a reliable reduction in spasticity. It does not prevent contracture nor orthopedic surgery. The safety profile, although on a systemic level may be okay in the lower GM-FCS levels, at the muscle level it has not been established. Spasticity reduction is at the expense of muscle, and that reversibility is not guaranteed according to animal work. So I would ask you, as I ask myself, is the price of spasticity management with botulinum toxin too high? Thank you.
All right. Thank you. All right. And now I'm going to have to follow that up. Okay. So I'm Mark Gormley. I'm a Gillette. As for disclosure, I'm going to have to make sure my clicker's working here. Let's see. My clicker's not connected. Here we go. I think it's clicking now. There we go. Okay. So I'm one of the bad guys. I get research support and speaker support from Allergan and Ipsen. And then we will be discussing, and Jason has already as well, off-label use of botulinum toxin. So we spent a lot of time talking about hypertonia and musculoskeletal deformities. And the reason why we do that is because these are we have treatments for these. And so we spent a lot of time talking about the things that we can change in a person. But even though we have all these treatments, we don't have good evidence of functional improvement long-term on anything that we do. It's not just botulinum toxin. I mean, we don't have good long-term functional improvement seen in SIMLs or SDR or ITB or even in therapy. And that's our fault. I mean, we need to do a better job of that. So I'm not going to argue with Jason on that. We do need to do a better job at that. But these are all considered standards of care. And so in the short term, we can maybe see some changes, but in the long term, we don't. And so there's a couple things. He talked about, should spasticity be treated? I'm going to give you a couple examples here. There's a matched pair of patients, GM-FCS 3s with cerebral palsy. In one family, the guy on the left, their family chose to do a rhizotomy, and the one on the right just wanted to do orthopedic procedures. And this is what they look like 10 years later. Now, the guy on the left has significant reduction in spasticity and has functioned much better. And the one on the right, their spasticity reeled everything back in. Her knees are pointing straight, but otherwise, she's had a significant deterioration of her gait over time and has had more problems. Now, I'm going to show you another video. Now, as Kurt Graham's son would say, I'm only going to show you my greatest hits. This is one of our spasticity patients that had a rhizotomy, and this is probably the closest we've gone to getting rid of cerebral palsy. So the first is a child with periventricular accumulation. We were doing some botulinum toxin at first on that child, and it kind of laughed at us and spit it out. And so we ultimately did a rhizotomy, and this is him 2 years later. So a significant improvement in his tone and function. Now, we did a long-term study, Munger here at Gillette, and found that rhizotomies had fewer soft tissue procedures and better range of motion long-term than patients that didn't in matched cohorts. And so spasticity reduction does have an impact on soft tissue contractures. And reduction helps. But the goal is not to reduce spasticity, the goal is to improve function. And so we have to keep that in mind. We don't want to treat a patient that's not having improvements in function. So Jason is exactly right. We want to improve function. We have short-term information. We don't have a lot of good long-term, so I'm going to concede that, but we do need that. So we're talking about botulinum toxin. It's the world's deadliest poison. 1 cup is enough to wipe out the entire population in the U.S. or 330 million people. what it does is it gets absorbed by the distal axon. It blocks the release of acetylcholine. Your neuromuscular junction stays intact. It forms new axons or sprouting, and then eventually that old neuromuscular junction begins working again over a number of months. At least that's what the studies show so far. And I'm going to give you another anecdotal example of what happens. So the child here is a 4-year-old with spastic diplegia from prematurity. And this is her walking. And then literally 1 month later after injections, her mother drove into the parking lot, opened up the trunk, pulled out the walker, and she walked in. This is a marked change just by reducing her spasticity and doing nothing else. And again, I'm showing you my greatest hits. Now, the next one, this is an adult. Now, you could have argued to the previous pages, she would have ended up there anyways at some point without spasticity reduction. However, this woman was an adult and she had significant dystonia. She doesn't have spasticity. She has hemidystonia. She wouldn't wear a brace because it didn't help. Nobody would do surgery because she had dystonia and they're afraid it wouldn't work very well. And then so she was having trouble walking more than 100 yards or 100 meters for the Europeans, or the rest of the world for that matter. And so we did botulinum toxin. We did it in her gastroc, and this is her a month later. So she went from walking 100 meters to walking 4 miles or 6 kilometers. And so she had a significant improvement in her spasticity just by injections. Now, we did her hand as well at one point, and it loosened it up and made it her feel better, but she used that tone for function. She really couldn't use that muscle for that hand for anything else, so we stopped doing that. We didn't figure that was enough of a functional improvement to continue that. But we have continued to do her leg over the last 25 years. This is an example of an upper extremity. We try to stay away from upper extremity, but this is a boy that developed a tremor in his right hand. He was right-handed. He switched to be left-handed. And then 2 months after we did injections, you can see him signing his signature on the right side. He's still better on the left side, but he's significantly better on the right and can use his hand for two-handed tasks. In this boy, we only really need to inject once a year so far to maintain this clinical benefit. But again, reducing some of that movement and that tone helped. Now, those are anecdotal stories. Now, I'm going to present a clinical trial. Now, people criticize the clinical trials that are sponsored by industry, and this was sponsored by industry. However, it was headed by Mauricio Delgado, who's a good, reasonably ethical guy. And that I was involved in this study, so I was one of the co-authors on the first one on the left, and on the right, I wasn't one of the co-authors, but it came from the same information. And Ann Tilton was the PI on this, another reasonably ethical person. And these studies are very well controlled, and it's really hard to pull off these double-blind placebo-controlled trials unless you have a lot of money. And that's why industry tends to be doing that. And they're not going to report a lot of their negative results. When they get a negative results, they'll go back to the drawing board, try to figure out what they did wrong. Can they improve it? Is this product good again? And they'll try again if they think it's reasonable. So in this study, they looked at 241 patients. They were randomized placebo-controlled trial. They showed that there was, in the short term, not a long term, because you can't do these trials, unfortunately, for 10 years, that spasticity was reduced in the treatment arms versus the placebo. And then when they looked at the goal attainment scale, which is a functional measure, they saw that the functional measures were also better in the treatment arms versus placebo. Now, I want to show you something else. Now, when you go to, this is a good trigger. It tells me I'm talking too long to a slide because it goes off to after a period of time, the clicker. Our clickers are on our phone for those who don't know. So you have to download a special website. Okay, this is one of my favorite slides. So I was involved in both of these studies. So the top one is Dysport. A study, the one we just talked about, and then the lower ones is a Botox study on the upper extremity. The PI on that is Darcy Fagan's, another reasonably ethical person. And the thing I like most about this is if you look at the two treatment arms, look at the pre-treatment. So I'm part of this, right? So I'm part of the behind all this stuff. The two treatment arms had a 90 and 80% efficacy when you looked at the physician global assessment. If you look at the placebo, 63% of the placebos also met the goals for being a responder. 63, so that's a huge amount. Now, there's still a significant difference between the treatment arm and the placebo, but the placebo works 63% of the time. So this is why you have to do placebo-controlled trials. You believe what you want to believe. And if we just did the placebo and didn't tell anybody and got 63%, we'd be telling everybody, see, I told you this stuff worked, and because we got a 63% efficacy. Now, if you look at the one below, placebo worked again, and it decreased the tone, but the treatment arms decreased tone more than the placebo, statistically significant. However, if you look at it, the placebo started the treatment arm started wearing off at 12 weeks, but the placebo knew it was supposed to be wearing off at 12 weeks, and it did so as well. And so the placebo even wore off at 12 weeks. Again, it just points out you believe what you want to believe. So if you don't understand American politics, look at these two graphs, because again, you believe what you want to believe. Ben, you want to go to the next one? Thank you. All right. So Botox, Dysport, Xeomin, all the different botulinum toxin products have shown that they have good efficacy. And so if you look at their clinical data, they also show that they have good side effect profiles. And so there's really hasn't been a lot of serious issues with it. However, Howell and Graham also pointed out that in the GMSS 4s and 5s, you do have to be careful. This is dangerous stuff, and it does spread. And so for the really, really compromised child, you have to be careful with it. You can't be too cavalier with the dosing. You can't be cavalier how you use this. There's a reason why we tell people that you can't inject any more often than every 3 months. And so you want to be careful with it. So the next couple of slides, if you could progress there, it just shows some of the data that abobotulinum and then also the next slide, onabotulinum showed. And this data didn't show any significant problems associated with it from an adverse event. Next slide. Okay, so again, talking about functional gains, we want to look at studies and how well they've been done. So Novak has done a couple of systemic reviews that are really good. And she looked at botulinum toxins, and what she graded them out as was as do it and probably do it in the two studies in 2020 and 2013. There was also a study by Copeland in 2014 looking at functional measures, the the Canadian Occupational Performance Measure in the CP child, and they showed at 16 weeks, again, it was short term, but showed at 16 weeks that botulinum toxin was better than placebo in randomized controlled trials. So Jason put out in Blumetti, in his study, he graded how good are these studies. And if you look at this, look at the ones that had the two studies that had all the green marks, the ones that they thought were the most well-designed studies. So you have the snake oil salesman, Delgado, in there. He's all green. And then his cohort, Copeland, is also all green. So next slide. So Graham. So Graham is the guy that came up with one of the best level 1 studies looking, and he wasn't connected to industry at this time, looking at a randomized control trial, looking at treatment group and control group, the HIP study. Jason talked about this. Now, what Graham did is he looked at hip migration after doing the injections. And what he found was, and he had a criteria for patients bailing out of the study and getting hip surgery. He found after 1 year that at 12 months, the control group, almost half of them needed to have hip surgery and exit the study, when the treatment group had 0. And after 3 years, half of the group needed hip surgery in the control group and about a quarter in the treatment group. And so there was a statistically significant difference in the treatment group in needing hip surgery after 3 years worth of this treatment. But that's not what he concentrated on. He concentrated on what was the hip migration. And because the hip migration could only be measured in patients that didn't have surgery, he kicked out the worst half of the control group, and he kicked out the quarter worst out of the treatment group, and what was left over he looked at. So he cherry-picked those kids, and he still found that the treatment group was better than the control group, but it wasn't that much better. So he said, okay, well, you really should do surgery. You really don't. There's no benefit from doing the injections. And so that's just not fair. You can't kick out the worst of your group and then assess what's left over. You have to look at them all in context, but it's hard to do if you're having to do surgery on those patients. So then he did a 10-year follow-up study looking at those patients, and what he found was after 10 years, the patients in the treatment group caught up with the need for hip surgery with the control group. But what he pointed out was that he stopped treatment with spasticity management after 3 years. So those last 7 years, he had those patients having spasticity, and then that spasticity reeled those back in, and they needed hip surgery. And so what this study shows me is that botulinum toxin hip bracing actually decreases hip migration, and stopping the injections and stopping treatment of spasticity over 7 years, that spasticity reeled it back in. So next slide. So again, I want to refer back to this, is that you believe what you want to believe. So Kurt and I looked at the same information and came up with different conclusions. Now, Kerr's a great guy. I love Kerr. I let him cut on my kid, but we came up with a different conclusion in this study. So next slide. Okay, now we talk about long-term consequences of botulinum toxin. Borodic, he's an ophthalmologist, in 1992 looked at 12 orbicularis oculi specimens that he took out, and these patients had been injected on average every 3.5 months over 3.5 years, so a lot of injections. And he found that they had atrophy for the first 12 weeks, but it resolved after 6 months. So there was no evidence of permanent denervation after multiple botulinum toxin injections over several years, and if botulinum had not been injected within 6 months before evaluation. So he found that all resolved within 6 months. And he saw 3 patients with fibrosis, but those are 3 patients that had surgery on the orbicularis oculi, and he attributed the fibrosis to the surgical scarring. So next one. And Williams looked in 2013 at 15 kids and found that 5 weeks after injections in their calf muscle, that there was atrophy, and we do see atrophy with botulinum toxins of 4 to 5%, but there was no adverse changes in strength. So the strength was observed, the 6-minute walking test was good, and also there's no change in what they call the tug or the timed up and go. Next slide. So, Fortuna. I like this study. This study's been used to show what the consequences of botulinum toxin is in animal models, and why we should be careful. Now, we should be careful because you do get scarring. And if you don't do things right with botulinum toxin, you will mess up the muscle. So you got to be careful. You got to follow clinical guidelines. I'm not going to argue that point. But in the Fortuna study, they looked at 3.5 units per kilogram, which is a reasonable dose for a gastroc, but they injected it every month for 6 months. So they hammered this muscle over 6 months. So the cumulative amount they got was huge over 6 months. So go ahead to the next slide. And so initially they found after 6 months of doing this, on that top one on the left and the controls are on the right, you see a lot of scarring, a lot of fibrosis. But if you look after 6 months of no injection on the bottom left, that muscle is recovering, and it's recovering quite vigorously. So even after hammering this much more than you would do clinically, because you never do this in a clinical setting with the way that they did it, that this muscle is recovering and it's almost close to normal. It still has some scarring and ways to go, but it is functioning closer to normal. Go to the next one. So again, you can look at the same information, but you believe what you want to believe. So next slide. Okay, Dukin. So Jason talked about Dukin as well. So he took the right leg and injected it, and the left leg uses as a control in these mice. And he injected with high doses that cause generalized weakness and respiratory problems. Again, much more than you would in a clinical setting. And what he found was by 1 year, fibers had returned to normal with little variation. And then in a corollary to that, at 71, looking at the same information, by the 4th of 6 week, fibers in the soleus became restored to normal. In later stages, some gastroc fibers became considerably larger than normal, but others showed extreme atrophy and disorganization. And so he did see some minor changes early on, but by 1 year, most of those changes had disappeared. So next slide. So again, if you look at the top one on the top left, you see that after 4 weeks, there is some atrophy and a lot of grouping, but down by the low, there's still some small grouping of atrophic muscles, but most of them also had recovered. So he is well on his way to recover after about 6 months. Next slide. Again, you can look at the same information and you can believe what you want to believe. Next slide. So this last one I'm going to talk about is Lee. He looked at 72 mice. He had a control group. He also had an injection group, and he looked at a treadmill or doing exercise in one of the injection groups, and then also keeping the other group sedentary. So next slide. And what Lee found is that if you exercise, you really can avert some of the consequences of doing injections with the fatty infiltrate and some of the scarring. And so exercise seems to be a very key component. And we talked about that you can't use botulinum toxin alone. It has to be used in concert with other types of treatments. And if you do, you're going to minimize or eliminate some of these consequences we see in the animal models. And we really just haven't seen those in the human models thus far. Next slide. Keep going. Next slide. Keep going. Next one. All right. So botulinum toxin reduces spasticity, improves function in the short term and probably long term, but we do need to do a better job of that. And it is safe with very limited adverse events. But again, you can't be cavalier with this stuff. You have to use it carefully. But if you use it judiciously, you can reduce spasticity as the double-blind placebo-controlled trials show and improve function. Next slide. Thank you.
Thank you, Mark. That was really enjoyable. I just wanted to say that we don't disagree about everything. I found this great quote from Mark back in 1999. It says, spasticity should not be treated because of its mere presence, but should if it interferes with some level of patient function, makes positioning or cares difficult, or causes discomfort. I couldn't agree with you more, Mark. I really couldn't. But I want to know why that most of the studies that you talked about have really focused on spasticity reduction alone rather than issues relating to function. And I think I know the answer. The modified Ashworth scale is really the creme de la creme of outcome measures for both Big Pharma and the FDA. And why is that the case? Well, botulinum toxin, as we've already shown in multiple slides here, it reliably reduces MAS scores really well. And the reliability of MAS, depending where you read, is moderate to good. But what about function? That's really not been as well studied. And it's a difficult bar to clear for botulinum toxin. And when I think about all these studies, I think about, well, if it all hangs on reducing the MAS, why not just serial cast, like Francesco had said? Space Bop study would say we'd save a bit of money as well while we're at it. Talking about Big Pharma, and Mark had mentioned it, that they won't report negative results, and they keep going back until they get something positive. And I think that shows it across medicine with industry-funded studies associated with more positive conclusions. And that goes for botulinum toxin as well. In a systematic review that looked at prospective comparative studies of botulinum toxin, about 50-50 were industry-sponsored or non-industry sponsored. But what was not the same was the conclusions, favorable conclusions that showed positive results for botulinum toxin were over 50% in industry-sponsored studies, but only 20% in non-industry sponsored. It seems a bit strange that you'd have that discordance. As well, if you look at the primary hypothesis confirmation success, industry-sponsored studies were head and shoulders above what was seen in non-industry sponsored studies. So I think we need to keep that in mind when we're interpreting all these results. I love to see the videos, and I actually love to see patients, and I'm really happy for them. But I have to quote Dr. Peter Rosenbaum via Dr. Karen Nelson from the NIH that the plural of anecdote is not data. You mentioned your greatest hits. I have my greatest hits too. I still have all those videos, and I remember those ones much more than I remember the bad results, and I think that's human nature. Let's talk about the law of diminishing returns. Repeated injections of botulinum toxin are in my practice, I saw it a lot, and then I would just kind of go on to orthopedic surgery when that happened and say it's just time. Neutralizing antibodies have been a common target and often blamed for this, but the literature suggests only 1% to 2% of patients actually had these antibodies. If you look at what we just talked about with respect to the animal models and a little bit about human, as I'll talk to you about soon, there's increased stiffness after botulinum toxin, increased collagen content, and a significant decrease in contractile tissue. So could it be that there's actually just less muscle left to affect after repeated botulinum toxin? I mean, could that be the reason? Speaking of human studies, Mark is right. We have a dearth of them right now, but there are studies coming. And if you haven't read this one from friends in Belgium, then I suggest you go do that. This is a study that looked at typically developing kids, a cohort of CP kids with cerebral palsy who are Botox naive or botulinum toxin naive, and another cohort of cerebral palsy who are not botulinum toxin naive. And you can see that for the typically developing cohort, muscle volume of the medial gastroc is high and collagen content is relatively low. In the CP group, as we know from previous studies, that the muscle volume is lower and collagen content is higher. We know that to be true. But if you look at the botulinum toxin group, collagen content is extremely high and muscle volume is extremely low. And these are all significantly discordant from each other. And I would say that, unfortunately, again, there's no histology, but this is a step in the right direction to say that botulinum toxin continues to cause atrophy and scar, even in human models. It's not just animals. This is another study, a human study, and I like this study from Western Australia. I don't necessarily agree with the conclusions so much. They did purport that muscle atrophy post-botulinum toxin is compensated by adjacent hypertrophy. They injected a gastrocnemius and had a 5% decrease, which doesn't seem like too much, and a 4% increase in the soleus. I'm not going to get into that gastroc is a different muscle than soleus and works differently within the gait cycle. I will say, though, at this early time post-injection, what happens later. I'd also like to know what happens within that volume. Remember, we talked about Fortino's study, which showed that muscle mass doesn't change that much. It's the constituents that change. And we know this could be actually happening there, particularly if you let things go a longer period. These kids also had previous botulinum toxin at least once. So although this is a good first step, and I applaud them for doing it, we need more. It's not just muscle. Osteosarcopenia, so osteopenia after botulinum toxin is well studied now, and I encourage you to look at Kelsey Davidson's report on this on Saturday. So now, after 25 years, we're finally getting some studies which help us to look at the deleterious effects of botulinum toxin. And this is a global effort with global perspectives. It's not just from Calgary or from San Diego. There's many places looking at this now. And when I was going over this debate and preparing for it, I couldn't help but thinking about my friend Martin Goff, who in 2005 put together this tutorial which will stick with me forever. Botulinum toxin and cerebral palsy, a time for reflection. I couldn't agree more I couldn't agree more now, but back then. But now I'd say we not only do we have to reflect, but we have to act. And thank you very much.
With my clicker here, so let me see. Whoops, now it's working. Go back to the slide before. All right, go ahead. I'm going to just mention real quick here because we've only got a couple minutes. So I want to talk about serial casting very briefly. Ackman in 2005 did a double-blind placebo-controlled trial and found that range of motion with botulinum toxin alone didn't help. So this is one of those treatments that you really have to use in conjunction with something else. It does reduce spasticity, but it may not improve range of motion. But they found that if you did casting alone, it improved range of motion, but only lasts 6 weeks. But the money treatment was doing both of them. And if you did botulinum toxin and casting, it lasted for more than 3 months. So they worked in concert together and worked better together than they did individually. So next slide. So cost effectiveness. So Jason mentioned the Dutch study. These guys got a lot of grief for this study, and they had to the point where they had to publish a rationale paper. I didn't know you publish rationale papers for a study that you published, but they did earlier in the year. And he's right. They showed no difference in the GMFM with intensive physical therapy versus botulinum toxin and intensive physical therapy over 12 weeks. But what they didn't mention is, and this is where you get the selective kind of what you're looking at, what they didn't mention is neither group got better. The intensive physical therapy didn't get better either. It showed no benefit to doing physical therapy. So now you had a study that cost $4,000 to do physical therapy, and then 4,000 euros and 2,000 euros for botulinum toxin. And they were saying that you didn't need to really spend the 2,000, but you also probably didn't need to spend the 4,000 according to their study, on physical therapy either, because it didn't work either. Now, I'm a big believer in physical therapy. I use it all the time. I think it's necessary for our kids. But when you look at these studies, they do oftentimes show something that's a little bit different. And they cherry pick looking at the combo with botulinum toxin, and they didn't look at the whole study when they're talking about their results. So next slide. So again, you kind of believe what you want to believe. So all right, next one. Now, go ahead and hit the slide. So this is a patient that's been injected every 6 to 12 months over many years. And this is a spastic diplegic patient with, can you hear it? I don't know if it's coming through. There. So this patient's been injected in his hamstrings because he's ambulatory, he's GMFCS1. He gets injected every 6 to 12 months. When he's starting to get tight again, he'll He'll call up, we'll check him out, and if he looks like he's losing range, then we'll go ahead and inject him again. And that noise that you heard was normal ENG feedback. So I don't want you to criticize my technique here, but it was normal muscle. So if somebody had that hamstring injected as many times as we're talking about, with as much toxin as he's had into that muscle, you would expect to hear something other than a really healthy, normal muscle. And it's really functioning very strongly and it's still pliable. Next slide. Again, that's anecdotal, but it's next slide. Now, we talk about anecdotal. Now hit the first, click once. If you remember this woman, she was first treated as an adult with a significant amount of tone. And she was in clinic a couple of years ago, and I had visitors, and I was showing her some videos to the visitors, and I showed this video to them, and she happened to be in clinic. And I asked her, I said, do you want to come in and look at your video? Because she'd never seen it. I said, yes. So she watched her video, and she started crying. And she looked at me, and she said, Dr. Gormley, I forgot I looked like that. So I want to show you what she looked like at that time. This is 25 years later. Can you click the next one? She still looks the same as she did the first month after we did injections. So she's had a significant improvement, and she gets injected I'd say about every 6 months, and sometimes she misses a few, but she's done really well. And when she's really tight, she'll call back and come back and say, hey, I'm really starting to spasm. Can you help me out again? Next slide. So, in summary, botulinum toxin does reduce spasticity, but that's not what we're looking for. We want it to improve function. And in the short term, it does improve function. At least the best studies that are out there show that, but we don't have long-term data. And Jason's right, and I think we'd all agree. Everything that we do needs better long-term data. It does cause atrophy, but in very large doses, less than 3 months apart, in sedentary muscles, you can get fibrosis and fatty infiltrates. You got to be careful. But if you use it like you're supposed to using clinical guidelines, you will end up with a healthy muscle, and it won't have any significant long-term consequences. And actually, the animal model studies show that as well. And so you only want to use botulinum toxin to get clinical improvement. And then you want to repeat it if you have some clinical deterioration, the hypertonia returns. So you got to make sure the decrease in their hypertonia with botulinum toxin helps. It's always an adjunct. It's almost never a sole treatment. And if you have a patient that's a probe, and I was picking on Kerr's study a little earlier, in defense of him, if you've got significant problems with your hips and you're trying to delay something with botulinum toxin, and if there's no clinical benefit from delaying, then just do the surgery. Do the surgery and worry about the tone after you're done. You have to work together in concert to optimize the patient's function. Don't try to just avoid surgery with botulinum toxin. That's the wrong way of looking at it. What you're trying to do is improve function, minimize the consequences that a child has from cerebral palsy, and use it in concert with everything else you have in your armamentarium. And also, you got to work as a team. This is really complicated stuff. And so you got to maximize function, you got to all work together. Next slide. So I'm going to leave you with this. So botulinum toxin is safe. It is effective. You can click the next one too. And if it's effective, it's used appropriately, but it's complicated, so you got to be prudent. And people talk about my anecdotal examples, but it is a window to opportunity. And don't tell these people they're anecdotal. Thank you. You can flash the next slide.
Oh, that was a lot of fun. You guys are phenomenal. So now I'm stuck in the middle. I have Dr. Jason Howard on my left. Oh, this left. There we go. And Mark Gormley on my right. And whether you are on Team Jason, Team Mark, or somewhere in the middle, where I guess I am, maybe that's Team Mason, we're going to move forward with some of the questions that we have from the audience, and hopefully a couple of questions that I have too, because you guys have really made me start thinking a lot about what we're doing with botulinum toxin injections. So the first question, and I'm actually going to direct this one to start with to Jason. So from Lauren Rosen, one of the benefits that I've seen to Botox is the ability to postpone surgeries, so kids are older and end up having less single-event multi-level surgeries. Is less surgeries not worth the weakening that we are seeing, or should we go back to operating on the kids when they're little and then again as they grow?
Thank you for that question. You know, I'm an orthopedic surgeon, and but I'm one of those orthopedic surgeons who would like to delay. I even would like to eliminate doing surgeries for these kids if it was efficacious for them and if it was safe. And as I said in my disclosure, I did about 10 years of botulinum toxin. I trained with Professor Graham, and he was a big proponent of it. And I learned from him. I learned from other people as well. And I thought I was doing well. But as time went on, I kind of felt like that things were not improving. And then the data started coming. And then, me looking at all this animal data and having Walter Herzog come over to my clinic to say, Jason, I just want to let you know that maybe this stuff is a little dangerous for your kids. And I didn't believe him then. It took me another 6 or 7 years before I actually really had a good look at it. So I don't think that it actually does. It doesn't prevent contractures. We know that. It doesn't prevent orthopedic surgery. I don't know that it actually delays it. We do the surgery at the right time. I'm using a lot more serial casting than I used to in the past. And I love physical therapy, and I think they have a huge role here. And I think maybe they've been overlooked. We definitely need more studies to show efficacy in those other modalities. As Marcus said, we're to blame for this. We need to do more for that. So I don't think it changes anything about orthopedic surgery. I think you get to the end, I just want to see them there with a good, healthy muscle that when I do an operation, it doesn't look gray and fibrotic, but it looks red and contractile. And unfortunately, I've seen several of these kids where I look at it and it looks like Duchenne muscle, and it shouldn't be in CP. So that's my answer, anecdotal answer.
Mark, do you have anything to say about that?
Well, obviously, I think that if you let spasticity continue, you're going to run into problems. And botulinum toxin is an adjunct to that. If you reduce spasticity, because we know it does reduce spasticity, it's easier to stretch out. It's easier for them to participate in therapies. It's easier for them to tolerate AFOs. It's easier to tolerate splinting at night. And so it is a nice adjunct. I would never use it alone. And there is a time when they get older, if they're still having some issues, in that time to do surgery is appropriate, you do it because you can hopefully get some longer lasting results. But I agree, you can't do surgery at a 4-year-old and expect to continue to do it as an 8-year-old and then a 12-year-old. We've seen patients that have done that. At Gillette, we don't do that anymore because we just ran into problems doing that. And we've seen that the outcomes are better and the patients like it, and they seem to do better when you keep their spasticity to a minimum early on.
Wow. Okay. You guys are making this really tough. It's not crystal clear to me yet, so maybe we'll go through a few more questions. We've got a little bit more time.
All right.
So, Mark, I'm going to direct this question to you. And in ambulant children who need to optimize muscle capacity for adult life, are the benefits of botulinum toxin worth the risks? And what do you tell families?
Okay, so you loaded the question with worth the risk. So there are risks. But if you follow normal clinical guidelines, it's really minimal. And so if you end up with a small amount of fibrosis or fatty infiltrate in a muscle that's much longer and easier to stretch out, and the child is much more comfortable and they have less pain and they're able to participate better, then yeah, it is worth the risk long term. We rarely use botulinum toxins. I mean, the patient I showed you that was an adult, and I'm injecting for the last 25 years. That's the exception. That is not nearly close to the rule. I mean, most of our children that we do injections on, if we do 10 years of injections, that's a pretty long time. And so we will do it early on, and then it is worth the risk because the risks are really, really small.
And Jason, do you use botulinum toxins in your practice?
I did for a long time. I did it for about a decade, and data changed my mind. And along with my own anecdotal observations in my patient population, so I wanted it to work. But I can't ignore when the data is mounting and the evidence is there. I mean, I think we are behooved to put ourselves outside of our own selves and think about the patients and think about what they would want us to do in the face of having evidence that is stacking up. And I think it's stacking up. Where we are right now is we don't have enough human studies looking at histology. We just got a grant to look at this through POSNA, and I'm looking forward to getting our results from that. But I would behoove people, this is an area where you should look into CP muscle, look into the effects of these different modalities, including botulinum toxin, so we can really do the right thing for our kids. So no, I don't use it. It's been over 5 years now since I've used botulinum toxin.
So
personally,
since you're not using botulinum toxin, and this relates to a question that Uni also has published, let's see. So one of the questions, a major impact of botulinum toxin on muscle appears to be on muscle volume. And then my understanding of that is that muscle volume is also lost when we do serial casting or orthopedic surgery and immobilization. What's the difference between muscle volume lost with botulinum toxin and with doing serial casting or post-surgical immobilization?
That's for me, right?
Yes, sorry.
I would say that there's different mechanisms at play here. When you look at botulinum toxin, actually volume, probably doesn't change as much as we think. And a lot of the studies say, hey, look, volume didn't change that much. It must be okay. It's okay. But it's not the volume. It's what's inside. It's the constituents of the volume. And just like we showed with Raph's studies, that these contractile muscle is replaced with fibrofatty scar, and the volume doesn't change that much. Even Williams' study showed that, and Siobhan Reed's study showed that. So basically, I don't think that the mechanism is different. With serial casting, the reason for serial casting came from the fact that it actually does allow you to add sarcomeres by spastic stretch. That's the way that muscles grow in length, by stretch. But happens with serial casting is the diameter of the myofibers does decrease. So they're losing some myofibrils or stuff along the way. I actually when I was looking at this, I was trying to find some more evidence for serial casting, and a lot of it's old. And I think that's another area where we need to look into it a bit more. I think that the amount of atrophy that happens with serial casting does rebound faster than with botulinum toxin, but that's my bias. I would say that in CP, the satellite cells are not doing so well, and they can't regenerate this muscle, whether it's getting hit by a serial cast or by botulinum toxin. But I know that botulinum toxin causes it to be replaced with scar. And I know that serial casting does cause sarcomerogenesis. So, it's sort of balancing those two things. Neither one is perfect.
Mark, you look like you had something to say about that.
Well, obviously I have a lot to say, but I wish we could slap that slide back up of the two graphs, right, with the placebo. You believe what you want to believe. If you look at we look at the same studies. That Fortuna study tells me that after 6 months of jacking some rabbit up with all kinds of botulinum toxin, their muscle still recovers. I wouldn't even think that would happen. And here I am, the proponent. So it depends on how you look at the study. If you look at the mouse study from Duchin in 1970, he even says after a year it gets back to normal. If you look at the best human study that we have out there that looked at, and there was, now granted it was an eye muscle, but you look out there and it looked at, it's a patient that got injected every 3.5 months with a large dose over 3.5 years. Within 6 months, the muscle looked normal and it didn't have any scarring. Now, why would an adult eye muscle not have scarring, but everybody else's muscle would? And then serial casting, if you look at the animal model, if you want to go back to the animal model study, if you look at serial casting, and we didn't have enough time to put all of this in the talk, but it stretches the tendon, doesn't stretch the muscle. And we know that. If you have a spastic muscle and you put it in a serial cast and you get improved range of motion, you're stretching the tendon, not the muscle. Now, you may be better off because they don't have as much contracture and they're able to generate power because they have more range of motion, but you're not improving the muscle. Now, what is lacking is that we know it lasts longer with botulinum toxin. What is lacking is, what if you do that in a muscle that's not fighting the cast, that's not spastic? And are you going to make that muscle stretch easier? Is it the spasms within the cast and you're preferentially stretching those tendons is what's making the change? But if you loosen that muscle up and get it to last longer, is that? We don't know that, and obviously that's speculation. But you can't, you can look at this data all you ways. But I think the data is mounting to show that we don't have long-term scarring and problems with that. Looking at the same information.
Jason?
if I could just respond to one aspect of that. I mean, you know, the funny thing about what you just said, Mark, is, you know, talking about serial casting, but the reality is serial casting is one of the most common adjuncts for botulinum toxin. And, you know, are you actually adding insult to injury now, combining both of these atrophy-inducing modalities? You know, you said you have to use it in conjunction with something.
Yes.
And most of the time I see it serial casting, to be honest.
Yeah, all right. You can. Am I still on? I don't know if I'm still on.
You are still on, Mark.
Okay, all right. I didn't know if we were cutting the mics on and off, and I can see you cut my mic off. So,
you guys are doing a nice job. Keep going.
Okay, all right. So, Sarah, all right, we got to look at function. All right, we worry about atrophy, but what if you have a muscle that's atrophic, but they function a lot better? Which one are you going to want? You want a nice, beautiful muscle that looks nice and healthy, or some kid that can run the 100 meters better than they could when they started, right? You're going to pick the one that functions better. Now, granted, there is a correlation between having a big, strong muscle and what your function is. You do have to worry about what are the long-term consequences of doing that over the long haul. Sometimes you want that. Sometimes you don't want the muscle to be super strong because they work better with a weakened muscle. But yeah, if I'm looking at a functional kid, and if their muscle is going to recover, if their atrophy, if you exercise, that atrophy is going to go away. Because anytime you put a kid in a cast for anything for 12 weeks, everybody's going to atrophy, but they can build it back up. But if you can stretch it out, get them functioning better, and hold it there, and let that muscle regenerate itself, yeah, you're going to end up with a better result, and you're going to have higher function, and you're still going to end up with a muscle you like. The other thing, too, is that if you look at hemiplegic, we all follow hemiplegic patients. When you look at a hemiplegic child's calf on their involved side, it's always significantly smaller than the other calf. And before we do anything to it, So there's lots of stuff, but that calf is way stronger than the other one, right? Because we can't control it. And we're trying to do something to control it so that you get them, functioning better. Again, you got to go back to function. And if it's not working for improving your function, then you bail and you try something else. I'm going to say one thing.
Jason?
We do all these things. I'm going to say 3 or 4 things, but I'm right now saying one thing. So we do I'm old, right? And so I've been doing this for 30 years. Now, I'm not so old that I don't know what was going on before we started doing all this, because I grew up with all this stuff, right? So we had rhizotomies and baclofen pumps and toxins right when my career started. All 3 of them started. And then we always had orthopedic surgery. And so I don't know any different. And so on my whole career, I'm worried, okay, am I jacking these kids up for no good reason? Am I not ending up with something that really is benefiting? It worries me. And we're doing all this stuff, and we're making them go through therapies, and they're wearing night splints, and we got surgery after surgery after surgery. And then you look at them, and you have to, you're strapping them into the wheelchair so they stand upright, sit upright, and all those kind of things. And then I do this program in Jamaica. I go down to Jamaica. I go down there 3 times a year, and they have nothing down there. And I see these kids that should be up and walking around, and they are all curled up, and they don't have wheelchairs, and they're not doing much. And I'm like, oh my gosh, I didn't know the human body could get like that, because I didn't know what it was like to have nothing. So I can tell you, I know that we're making a difference, but I don't know what part it is, but I do know that we're making a difference.
Jason.
Oh, let us know.
I'm not sure what to say to that. I mean, I appreciate your passion and I respect your career. I mean, I think you brought a lot to the profession. But I mean, just as I went through this sort of, sort of epiphany, I guess, I think you have to be open to evidence as it comes. And I think in this case, there is smoke. And, and often when there's smoke, there's fire. And we're just at the tip of this now. We need to move further. I don't think you could disagree that having all these multiple centers, they can't all be wrong, showing pretty well the same endpoint for this muscle in different animal models, different techniques. I mean, we have to be honest with ourselves, put ourselves behind, and and do these studies. We owe it to our kids. We owe it to ourselves. We don't want to have this as our legacy. So I would behoove people to just look at the studies that we presented today and make your own conclusions, and look at it critically. Try and put yourself outside yourself. I think you'll find that you're going to go, well, you know what? It's a bit worrisome, and maybe we need to know more. We might not have all the data right now, but to be honest, 25 years of data for botulinum toxin, and we still don't know if it helps your function. And we're finding out that it doesn't help contractures, and it doesn't put me out of business. So where are we here? I think at least we owe to look at this more closely from the basic science standpoint, look at muscle histology, and really see what's on. Because the clinical data is not really helping. It's not helping your case. And the animal data and the emerging human data is corroborating that. So I'm worried. When there's smoke, there's fire. I don't want to do this to my kids if I don't know these things. I need to know if this is true or not, and I think we all do.
I really thank you both for your passion with regards to this topic and your presentation of all the data that helps support your area to give us something to think about. As both a physician and a parent of a kid with CP who has gone through botulinum toxin injections, who has gone through rhizotomy, who has gone through orthopedic surgeries, I've seen it from both sides now, and I understand the need to be thoughtful and have had some of the same questions Jason has, but have also seen the magic like what Mark has shown in some of his videos. So it makes it very difficult. And we would like to try something. We'd like to try and do a poll to see what you guys think or where you're at this point. So if you could please complete the poll. I'm hoping this works. I haven't done one of these before on this platform. And is the poll up and running? Well, look at that. I didn't warn you guys that we were going to do this.
No, you didn't. You're evil. I'm not looking.
I'm okay with that. You guys are a lot of fun. I have really enjoyed, I have been entertained and educated, and that is something tough to do, especially being on a virtual meeting all day and keeping all of our attentions right to the very end. And I think a big part of that is the passion that you guys have for this. That's phenomenal. So it looks like we've got pretty much, wow. So I'm beginning to think that we may have a lot of Team Masons out there because it's very close. If this was a presidential election, there would probably be a recount.
No, it's 54-46. That's good. That's pretty big.
We don't know the margin of error for this very unofficial poll. So I want to thank you both for your presentations tonight. Dr. Howard, it looks like you might have just squeaked out a victory here, but you both had phenomenal arguments. So thank you. And please, everybody stay tuned for the special recognition that we are doing next.
That was great. Thanks, Mark. Appreciate it.
Oh, I'm not sure.
Ben, can you pause it?
I have one favorite thing about Susan.
I need to do an intro before we start the video. There we go. Hang on just a second. So this is kind of a surprise for Susan. And I really want to thank you all for staying tuned with us for the special recognition. Susan, Jeremy, I, and everyone on the program planning committee, and frankly, the board of directors, and I bet most of you were incredibly devastated when we realized we couldn't have an in-person meeting this year. In fact, if we were in New Orleans now, we would be at the networking dinner. We'd be mingling, catching up with colleagues and friends, making new friends, meeting new people, and congratulating our new president. The annual meeting is time for Academy members and attendees to get to know our new president. And in getting to know a person, it's not always about meeting and talking to that person, but also about what others have to say about them. And let me tell you, a lot of people have a lot to say about Susan. So many that we had to limit those we asked, or we would have been here all evening. But the things said about her are not only amazing, so are the things she does. And we can give you a glimpse into the life of Susan thanks to her husband, Jim, who has also put together a photo montage. Her smile is unmistakable. For those of you who know Susan, I think you will see that we are able to capture much of her essence. For those of you who haven't met her yet, please keep watch to get to know the perseverance, kindness, diligence, and dedication of our new president. Our Academy is in excellent hands with Susan at the helm during these unprecedented times. On behalf of my co-chair, Jeremy Bauer, and myself, please grab your glass of wine or water, mug of beer or root beer, or whatever your beverage of choice is, and join us in this special recognition of Susan Cienko. Okay, Ben.
Oh, I'm not sure I could have one favorite thing about Susan Cienko, but I can say that Susan is always upbeat, always energetic, and always resourceful. She's got an idea or an app or a website or a way to make something work. That's why I knew that Susan is the perfect president for this upcoming year and the challenges of the AACPDM, because she will figure it out. She will figure it out with a smile and a laugh, and then she'll go have fun celebrating her success. Wishing you all the best, Susan. Thank you for letting me talk about my good friend Susan Cienko.
Susan, thank you for your guidance, your leadership, your patience, your humor, and your thoughtfulness this year. I am so grateful to be working and learning from you. And while this year's unmasking isn't exactly what we had in mind when we were planning the meeting from the beginning, the theme turned out to be perfect. Here's to you helping to unmask all of our potential. I'm looking forward to working with you as our next president.
Well, it seems that we need to become movie producers these days to communicate with each other. And actually, I'm starting to like it. No, just kidding, okay? So the question is, what's my favorite thing about Susan Cienko? Well, for me, it's her positive and cool approach to crisis. Her smile always transmits peace, hope, love. I believe we could not have had a better person to lead this year's annual meeting organizing committee than Susan Cienko. Do you know she and her team had to plan for 3 different meeting formats in a very short period of time? And she never expressed any despair or frustration. She kept smiling. You will never guess that she was facing one of the most challenging times the Academy has ever seen in its history. Susan Cienko, you are an amazing leader, and I don't have any doubt you'll become one of the best presidents this Academy has ever seen. Congratulations.
Hey, Susan Cienko, this is Christy Bjornson calling, and I just want to let you know that I have some great memories of meeting you actually at an AACPDM meeting many, many years ago, sitting down next to you in the back of the room listening to abstracts, you sitting next to Catherine, and all of us just watching all these various people talk about their R01s, and then the whole journey of going back to get your PhD. And you have mentored me on many levels. You have mentored me as a researcher, as a clinician. You've mentored me as a parent. I just have always really appreciated all that you've given to me personally, as well as to our Academy. So here's to you. I wish I had a glass of red wine to drink here with you. I will be drinking this during the tribute with you over the Academy meeting. And I just want to tell you how much you are appreciated, and we really appreciate everything that you've given to our Academy. You rock, girl. Thank you so much. Take care. Bye-bye.
Hi, Susan. Like many, I admire your persistence and your contributions to the American Academy of Cerebral Palsy. I have followed your career since your days in Chicago at the gait analysis to your successful journey in Portland. However, my favorite memory by far for you is based on your foundation. And you know what I mean. I mean those place where the rubber meets the road, which is your contribution to fantastic knock your socks off footwear at the Academy. I was so looking forward to this year, watching you ascend the little ramp so that I could see what kind of shoes you were wearing. And believe me, I had picked out a few cute pairs myself for the dance floor in the meeting. But I will be there. I'll be smiling in the first row and congratulate you on what I know will be a successful year for the Academy. Thank you.
Hi, Susan. Congratulations on becoming our newest president and leading us forward for the next year. I have always appreciated your direct, no-nonsense style, couched in your wonderful down-to-earth sense of humor. And I would suggest that those are the tools that you're going to need in leading the board of directors. Be direct, accept no nonsense, and maintain your sense of humor. When I became president in Milwaukee, Wisconsin in 2013, Maureen O'Donnell handed me a cheesehead to mark the occasion. Well, given that we would have been in New Orleans, I thought you needed something to mark the occasion. And so this is the updated version of the Venetian plague mask, which is appropriate for your position and has been personalized for your role as president of the AACPDM. This little item is designed to really match any ensemble, and it is guaranteed to help you maintain social distance in any environment. So wear it in good health, and we look forward to a wonderful year. Congratulations.
So the question, what is my favorite thing about Susan Cienko? I can't come up with just one thing. There are so many. We've worked together for so long, and I've never seen her working at less than top speed. She is always enthusiastic, has an incredibly positive attitude, even in this current situation in Portland, smoky Portland. I've never heard her say no to anything reasonable, and even many unreasonable requests that I've probably made. She kind of keeps me on top of things, keeps me going, and does so many things at one time. I don't think she knows the definition of multitasking, because that's her usual mode of function. My life and career have been enriched by my relationship with Susan, and I hope she continues on in the same vein, and I congratulate her as president of the CP Academy, where obviously she'll do an incredible job in spite of all the challenges.
Congratulations, Susan, on becoming our next president. I just want to thank you for all the hard work you've done for the American Academy, not just this past year in preparation for the meeting, but for many, many years. And we are so lucky to have you in this leadership position. And I know you will do an amazing job. I've seen you on a Zoom meeting. I've seen you carry out, participate, fully engaged, and continuously toss a ball to your dog. So I know you can do anything. Congratulations.
Hi, Susan. I am so excited to get this chance to tell you thank you, thank you, thank you. I know that there have been a lot of ups and downs, and hopefully by the time that you get this tribute message that you've really got to experience most of the ups from our work and for the conference coming to the time where we get to share it with everyone. But again, this has been hard work, and you're almost a famous footnote for the future historians today, our awesome president who helped us with the transition to the first ever 100% virtual meeting, which was also awesome in its own way. I'm sure that's what we'll be saying for years to come. So again, please know how much you're appreciated. It's been awesome getting to know you through the board. You're a very genuine person, and I'm just so excited to see you lead us, and I know that we've got some exciting things coming our way and our chances to grow and to connect with other people, both colleagues and our patients. So thank you for leading us. Thank you for all this hard work, and I hope you have a great day.
Susan, first of all, I just want to say thank you for the opportunity to be scientific co-chair with Julian Brandenburg this year. It's been a real pleasure. You really showed off your strengths this year in your ingenuity, in your creativity, in your persistence, ability to think outside the box. And it just really shows your passion for good quality research and your commitment to the AACPDM. So thank you.
The first thing that always comes to mind when I think about Susan is her smile. It didn't matter if it was an annual meeting or a board meeting or a committee meeting. I always knew that you were going to be met by the incredible effervescent smile. That smile that said so much more about an open heart and a loving heart and a mind that was open and welcoming to every human being, including me. And that is the thing that I will certainly always remember and I always look forward to every year at the meeting. Congratulations, Susan.
Dr. Cienko, ever since I first met you at the site visit in New Orleans, I've been impressed with your enthusiasm for the meeting, and you continue to keep up that enthusiasm this year through all the changes that we had to go through. Your passion for the Academy is contagious, and it's been wonderful working with you. I appreciate so much how well you support your colleagues, how much you do to support the staff, and of course how much you do to keep upholding the mission of the Academy. Thank you for all you do, and congratulations on a wonderful and successful annual meeting.
It's really difficult to come up with a single favorite thing about someone as interesting, talented, and multidimensional as Susan Cienko. But if pressed, I'd have to say that it's also the thing that I'm going to miss most about this upcoming meeting, and that is the ability to share a drink with you. These last many years, I've really enjoyed having the opportunity to have a beer and a laugh with you. You've made me smile, we've cried occasionally together, and you've always taught me something. And for that, I am most grateful, and I will really miss that this year. But I look forward to having a virtual beer with you. And I want to congratulate you, Susan, on becoming our next president and for being the only person in AACPDM history to have had the opportunity to have planned 2 meetings in the same year. I know that no one could have done it with the same grace, wit, humanity, and skill that you have. And for that, I am really thankful that you are our current president and leader. Congratulations.
Hi, Morgan and Sydney Thomas here. We just wanted to say congratulations to our mother on such an amazing accomplishment. We are so proud of you and we can't wait to see what the next year brings. We just wanted to say that obviously our favorite thing besides you being our mother is that you put so much passion into everything. You've shown us what truly hard work looks like, and both Sydney and I are so inspired and motivated by you every single day. We're so fortunate to have someone to look up to who works as hard as you do, and you really have given your heart and soul into everything. We just want to say congratulations one more time to our amazing mother, and we wish we were all celebrating together in New Orleans. Congrats.
Hi, Susan. Congratulations on your assuming the presidency of the American Academy this year. I know it's the cap-off for you of 25 years of hard work on behalf of the Academy, and I want you to know that everyone has always appreciated it. On a personal note, thanks for taking over the website when you did. You took it to a level which I never could have imagined, as it turned out. I know this year has not been easy for you, with lots of curves being thrown due to the COVID crisis. But if anyone could have done this, or would have done this, it's you, and I have no doubt that the meeting will come off in a stellar fashion. I will miss our in-person conversations about family and friends, but look forward to working with you again on the board. And I just want to again offer you best wishes, congratulations, and Godspeed.
Hi, my name is Sylvia Owenpoo, and I've known Susan for a very long time. Actually, since our shared University of Waterloo days in Canada, and she's been a dear friend and colleague ever since. During these years, or actually now decades, our lives have shared many parallels, both at work and home. So to think of my favorite single thing about Susan is very difficult. I have many. But one thing I really admire about Susan is her energy and dedication to the tasks that she takes on. When I think about the number of professional meetings she has planned, research grants conceptualized and written, as well as homemade quilts and preserves, the list goes on, and I am amazed. Thank you, thank you, thank you, Susan, for your energy and dedication to the American Academy of Cerebral Palsy and Developmental Medicine. especially during this very challenging year. And thank you so much for being such a good friend.
Hi, Susan. Thank you for being a multitasking extraordinaire, for all of your service to the Academy, for appreciating good chocolate, and for taking the time to get to know people. I'm looking forward to a great meeting that you've worked so hard to plan and a wonderful year ahead under your leadership. Congratulations.
My favorite thing about Susan is that nothing phases her. When I first met her in 2006, she took on the project of revamping the Academy's website. She's been the Academy's guinea pig for many projects since then, including the virtual annual meeting. Thank you, Susan, for being the person that you are.
Hi, Susan. One of the things that I admire most about you is your incredible work ethic. And if I take an example from nature, and this is our AACPDM beehive, you are not a drone who may go his entire life without working a single day. You are an incredible worker bee. You can see them kind of going in and out there with lots of pollen. Well, this year, Susan, you are our queen bee, and I hope that your presidential year is as pleasant and fun as I know it will be productive. Thanks for all that you do.
So the best thing about Susan, it's kind of hard to summarize in just a word or a phrase, but I think that I would say, Susan, it's your Rock of Gibraltarness. When I think of the Rock of Gibraltar, I think of this steady, amazing force. It is there through thick or thin. It is something that you can depend on. And those are all qualities that you have and that you bring to the Academy. We're so lucky to have you stewarding us through this strange year and this novel video event, and you've done it all with such steadiness and gratitude, and it's just lovely. So thank you, thank you, thank you. We are fortunate to have you at our helm. Congratulations.
Hey Susan, it's me, Maureen O'Donnell from Vancouver. I'm here to say congratulations on becoming president of our Academy. I know the day that I became president back in 2012, I was quite emotional. I felt honored and I felt excited, and I'm sure you're feeling the same way. I think that your year is going to be a year for the history books, just like your year planning this virtual meeting. Our first virtual meeting has been one as well. And I think you're just going to be really well positioned to do a great job for our Academy. You know, there are lots of things I really admire about you, but three of them I think will really help you this coming year and help all of us. One is your true can-do, get-it-done attitude. You never take something on that you don't complete. Second is your ability to really, truly listen to people and incorporate people's ideas and bring them together. And then the third is your sense of humor, which is fantastic and likely will be required. So I definitely wish you well. I wish we were coming together at the meeting so we could say these things in person. I will miss seeing you. We always have fun together, whether it's going for a walk to try to find coffee or having dinner together or cooking together or singing and dancing with the avatars at the ABBA Museum in Stockholm. It's always a good time. And so I'll miss seeing you this year, but look forward to when we can all come together again. So all the best for a great meeting, and have a really fun time at the virtual meeting. I know it's going to be great, and enjoy your year as president. And if you need anything, I'm definitely here to help. Know you can call anytime. Oh, and by the way, I'm supposed to say something about what my favorite thing about you is. Well, there are lots of favorite things, but I'd have to say your sense of adventure. You're never shy away from anything. You're willing to try anything, and that is a great way to be. Bye, Susan. Enjoy.
I'm so happy to share my tribute to Susan Sienko. One of my favorite things about Susan is that she's so fun-loving. I can't imagine being a part of the CP Academy without Susan having such a central role, from her webmaster days to now being president of the Academy. It's so well deserved. There's She so clearly loves our organization. She loves caring for the children that we all care about and have made our careers trying to improve their lives. And Susan always comes up to me and is with that bright smile and fun-loving spirit, asks about my family, and we just share a lot of great memories about the Academy over the years. So I'm very thankful to be a part of this tribute, and just want to say congratulations to Susan for such great accomplishment, and I'm so thankful for your leadership through the Academy.
Wow, Susan, my favorite thing. I don't know. I mean, of course she's smart. She's knowledgeable. She's efficient. She makes you feel great, and she's so nice and fun to have around. But my favorite thing? Probably how she always shows up with the finest quality chocolate or coffee or wine. I mean, what more could you want in a friend? Congratulations, Susan, on this meeting. We're excited to have you as president of the Academy. All the very best.
Susan, thank you for your dedication to the field. You have a long history of clinical care, research, leadership, and volunteerism, not only for the American Academy of Cerebral Palsy and Developmental Medicine, but also for the Gait and Clinical Movement Analysis Society. Did I mention persistent? You've been doing these things for longer than any of us cares to admit. And what about tenacity? You've been tenacious all the while, somehow with a smile. And somehow no more true than any time than in the past 2 years. Susan, thank you for being you.
Hello, Susan. Congratulations and my very best wishes as you assume the mantle of president of the AACPDM. I've known you for well over 20 years, and indeed, my earliest memories of the Academy involve you, not only as a standout member of the Portland Shriners team, but also as one of the Academy's proudest cheerleaders, as a fellow committee and board member, webmaster extraordinaire, a fellow Canadian, and as a friend. Throughout, I have admired your ideas, your boundless energy and enthusiasm, your positivity and good cheer, and enjoyed every minute of your great company. Often well into the wee hours, and almost always with a good beer. It was therefore a very special thrill that in my role as past president a couple of years ago, my most important and enjoyable responsibility was the privilege of calling you to share the news of your nomination as president for 2020. Susan Sienko-Thomas has a real nice ring to it. As first vice president this year, you've no doubt shouldered the huge burden and responsibility of organizing this year's annual meeting, made all the more complicated by this awful pandemic. Congratulations for the brave decision to hold the meeting virtually. Although it seems such a shame that we will be unable to come together in person in New Orleans next week to enjoy the fruits of your labor, we are all looking forward to the virtual meeting that I dare say will be one we shall remember in the years to come. Meanwhile, the Academy is in terrific hands with you at the helm, and I can't tell you how proud I am that I was able to play a small part in that decision. I look forward to your year as president and can't wait to give you your purple, green, and gold beads and a big hug this time next year in Quebec. Bye and congratulations again.
Susie in the sky with time. Hi, Susie. You recognize me? It's me, Jan Willem. I think you are unmasking my potential here. Thank you so much for being our leader for this virtual academy meeting. It's amazing the job you're doing that nobody has done before. We make a great team, and what I like about you is always when you are in a meeting and throwing the ball for your dog. You know I'm a dog lover, so I always laugh at you. Hope to see you soon for the after party after the virtual meeting, and we will raise our glass with champagne. Bye.
Hi, Susan. This is not a call about the budget. It's not a last-minute panic call. And it's not to show you my little fuzz hair either. On the contrary, it's to thank you once again for all your contributions to the Academy, and in particular the last 6 months, which have been, as we all know, unprecedented. What you and the program committee with Jolene and Jeremy have done is absolutely wonderful, and the Academy owes you a great deal of gratitude. I actually look forward to working with you during your presidency. I hope that we can meet in Chicago in person so that hopefully we'll be able to have at least a little laugh about what has transpired during this time period. So again, I thank you. I thank you on behalf of the other members of the board and the Academy. And again, I look forward to working with you. And I have one request, that you just try to take it easy on me and that you don't make me look like that, okay? All right. Hopefully see you soon. Bye-bye.
Hi, Susan. Diane Damiano here. Congratulations on being our next and notably female non-physician president. You've always had such a positive energy about you, which was evident when I first met you when you were hosting the meeting that joined the East and West Coast Gate Societies, and which has also been very evident in everything you've done over the many years for this Academy. You and I have shared a lot of wonderful memories over these years, and now we're sharing the meetings that have been disrupted by global crises. Mine was 9/11, where we didn't even have a meeting, and now, of course, with your meeting during the pandemic. But I know of no one better than you to really take this enormous challenge and make something truly exceptional out of it, as I'm sure you will. So best of luck with your meeting. Best of luck with next year being president. I love you.
Susan, congratulations on becoming the incoming president of the American Academy for Cerebral Palsy and Developmental Medicine. You have such great enthusiasm for everything you do, and I know you're going to provide fabulous leadership. Susan, you're the bee's knees.
Hi, Susan. Jen and Bauer Lyman coming to you from New Orleans. Bauer had to display his mask for you. We wanted to just make sure that you knew that we were thinking about you down here and wishing you all were here. I've really enjoyed working with you this year and learning from you and watching you face adversity with a smile and twinkly eyes and really just, make such a meaningful, positive impact in a time where things really haven't been that positive. So thank you for everything you're doing. Thank you for unmasking the potential in all of us and all of these awesome kids and individuals with cerebral palsy, and keep up the good work. I'm looking forward to your presidency over the next year.
So as we wrap up with a beautiful photo montage of Susan from her husband, I want to thank you all for attending. Thank you all for your participation. Thank you all for your patience with us as we're learning what it's like and what it means to have a virtual meeting. I will not put Susan back on. This was a total surprise, so I thank all of you who contributed to the video. I thank all of you who would have contributed to the video. This would have been longer than we could stay up tonight if all of you had said all the kind things that you have to say about Susan, because they're true, and that's what she is, and that's what she does. I also want to thank you for being here this late. So please join us again tomorrow. We have one more day of this incredible, unprecedented Academy meeting, and stay with us, and don't forget to tune in after October 5th to watch everything asynchronously. Thank you.